My name is Michael Cain. I'm a clinical electrophysiologist, and I currently serve as Vice President for Health Sciences and Dean of the School of Medicine at the University of Buffalo in Buffalo, New York. The topic of my presentation today was dealing with risk stratification for sudden cardiac death. And individuals who have survived a myocardial infarction are at increased risk for developing sustained ventricular tachycardia, ventricular fibrillation. We know from multiple studies that implantation of an implantable defibrillator has a favorable impact on saving lives in certain patients who have survived a myocardial infarction, particularly those with an ejection fraction less than 35%. The limitation of relying on left ventricular ejection fraction alone as the only way to determine who will benefit from an implantation of these kinds of devices is that the positive predictive accuracy of relying on ejection fraction is quite low. And that simply means that we end up implanting defibrillators in a larger number of patients than who will actually benefit from having that device implanted. And over the last 30 or 40 years, there have been other tests that have been developed and prospectively tested to see whether or not they improve the positive predictive accuracy that is a limitation, as I said, of the current approach, which relies on ejection fraction. When tested alone, these newer testing methods, if you will, their performance has been similarly disappointing. But two things have come out of the last 40 years of research. One is that when using these tests in combination, one preserves the high value of the negative predictive accuracy, and you actually do improve the positive predictive accuracy of the approach when tests are used in combination. But even when used in combination, the data still aren't good enough to really allow us to definitively determine the best approach in improving risk stratification. And so another approach is to look at novel ways to risk stratify that aren't based on the current methods, which rely on detecting the anatomic electrophysiologic substrate that's produced as a consequence of myocardial infarction. And so the new data that we presented today was using positron emission tomography to determine the volume of myocardium that is denervated as a result of the injury produced by a myocardial infarction. And the results demonstrated that the volume of denervated myocardium was a highly predictive finding for identifying patients who would go on and develop sudden death. And the volume of denervated myocardium, its predictive value, was higher than the traditional one that's used, which is ejection fraction, and interestingly, more predictive than the volume of infarcted myocardium or the volume of hibernating myocardium. So the end result is that we're hopeful that using the positron emission tomography imaging approach and identifying the volume of tissue that has undergone denervation may be a very powerful predictor alone, or hopefully would add to the positive predictive accuracy when used in combination with more traditional methods.